Thank you also to the organizers for inviting me. I'm enjoying being here in Hong Kong a lot. You gave me a very difficult task, though, to try and make an argument for transplant after Dr. Thalmann and the people from Taiwan. AML is becoming a very complex disease, and when I got this task, it's a daily question that I've dealt with for many years: who should be transplanted? And the standard answer is high-risk patients get transplanted because they benefit from transplant. And good-risk patients don't get transplanted because there's no advantage from transplant. Young patients get transplanted, old patients don't get transplanted. I'll try to make an argument that transplant is by far the most effective treatment, that many more patients should be transplanted, and that with the exception of APL, there's very few situations where transplant is an inferior treatment. So why not transplant everybody? And why do not all patients get transplanted? And what is there? Is it a misconception on our part as the transplanters? Is it a misconception on our colleagues in leukemia? And let me show you some data. So I showed you this yesterday already. Transplant started with a demonstration that matched siblings were necessary for successful transplants, and these are the old dog models, and this comes from 1968. But then 1979 already, these are data from Dr. Thomas, New England Journal of Medicine, transplanting patients in first remission with cyclophosphamide and TBI, 19 patients. But look at this, 60% of them seem to be cured. Hard to improve that with all the risk factors that we have identified. We didn't know about FLT3, we didn't know about CBP alpha, we probably barely knew about translocation 15-17 at that time. So this was quite an effective treatment. Since then, little by little, chemotherapy has improved. But is it better than this? Is there a reason why we should not do this for most patients? It's a question that has been not really addressed in randomized studies, because it's traditionally been hard to do randomized studies. It's for a randomized study you need fairly easily accessible patients, and for a long treatment strategies, and for a long time transplant has been offered only to those with matched siblings. Now this is the second best that we can get to a matched sibling to a randomized study. It's a Dutch study or a European study where patients who had a matched sibling were offered transplants, and those that didn't have a matched sibling did not get a transplant. And as you see, with somewhat old-fashioned categorization, there was no FLT3 yet, there was no NPM1 yet, but transplant clearly benefited those with adverse cytogenetics, with almost a doubling in outcome, but still not a great outcome with transplant. It's not like transplant is a wonderful curative procedure for everybody, but it is clearly better than no transplant or transplant at the time of relapse. For standard risk patients, those typically with normal cytogenetics, transplant was still superior. And even for those with good risk disease, transplant was at least equivalent. The difference here was not statistically significant. But I often wonder, why do we then say we don't need to offer transplant? It's not inferior. So you could make a very simple argument. Why not forget about all these categorizations and offer transplant to everybody? And overall, the outcomes will be better. A couple other ways to answer this. There's a review of all the prospective trials like this conducted by Dr. Corrett, published in JAMA. Dr. Corrett, I believe, is at the Harvard, at the Dana-Farber. And in most of these studies, the patients who had a donor had a better outcome. As you see here, the line that shows equivalence, overall, the larger studies are the ones with the largest impact, with the largest dots, and most of the larger studies show at least some beneficial impact in survival for transplant. And then going to the lower points here, the transplant was mostly beneficial for those with high-risk disease, still somewhat beneficial for those with intermediate disease, and equivalent for those with good risk disease. So again, clearly transplant is a superior treatment for those with high-risk disease. It's equivalent for those with good risk disease. So there are very few situations where allotransplant is inferior. But a third, what I think very interesting situation analysis is the analysis from a Japanese group, Dr. Kurosawa, who did a Markov decision analysis, which is a complex statistical technique where they assign a certain benefit to various treatment decisions. And they reviewed in this way 2,000 patients in Japan who were in first remission, and they reviewed the treatment decisions and their outcome. So 1,000 had their HLA checked. Of those, half had a related donor, and half of that half underwent the transplant. Others didn't have a related donor or didn't have their HLA typing checked, and some underwent an allotransplant from an alternative donor. So others never got transplant or only got transplant after relapse. So ultimately, of the 2,000 patients, only a quarter underwent transplant in first remission. Now, then they went on, they did this analysis. Again, they gave what could happen to patients if they had transplant in first remission. They could either relapse without GVHD, or they could relapse, they could have no relapse without GVHD, they could have no relapse with graft versus host disease, or if they were not transplanted, they could be cured, they could have a relapse and then either die or get a second transplant. Now, importantly, they assigned in this study qualities of life to various situations, and they thought, listen, if you get a transplant and you're cured without graft versus host disease, that gives you quality of life of 90% of normal. However, if you have chronic graft versus host disease, your quality of life goes quite a bit down. And that's realistic. I think we've all seen that. They said your quality of life is only 60% of normal. And that was somewhat an arbitrary decision. So they assigned weights to this. Similar, if you relapse, your quality of life right away goes down to 50%. If you get a second remission, it goes back up, and so forth. Taking these weights into account, then they found that transplant was superior somewhat for poor risk patients, for intermediate risk patients, was inferior for patients in complete remission. And I think this translates actually a lot of our thinking. People are scared of transplant. People are scared of transplant. Why? Because not because they think it's an inferior treatment. It's clear that patients relapse less, but sometimes quality of life is much reduced, and that holds people, and it's much reduced from chronic graft versus host disease. And so this probably is a reflection of what really happens in the mindset of patients, of doctors making these decisions. Importantly, they found that transplant had most impact in younger patients with poor risk leukemia and in older patients. Now, so again, why do we not transplant more patients? Why do they not get referred more? Why a quarter out of 2,000? I believe there's also some misconceptions. One misconception is people don't have a donor. Yesterday, we talked a lot about transplant, haplotransplant, cord blood transplant. There's a number of studies now showing that with high-resolution typing, and Dr. Thalman showed this already, and I could show you 10 studies like this, but with high-resolution typing, those patients who have an unrelated donor do quite well, and their outcomes are quite equivalent to those who have a matched sibling. And this is a French study, as I recall, one of the first studies showing this, survival and treatment-related mortality quite equivalent between matched unrelated donor and HLA-identical sibling. Now, many patients don't have a matched unrelated donor, particularly patients of non-Caucasian ethnicities. And I showed you this yesterday, that at our institution, or at my previous institution, I would say, with our haplocourt procedure, outcomes now, again, are almost equivalent, or are equivalent as far as survival are concerned. I'm not going to deny that there's still some problems, but these procedures have improved. And I just show this as an example, but you could equally show the data from Beijing that we were shown yesterday, where 800 patients had haplotransplants in first remission, and their results, if anything, were superior to those of matched sibling transplants. So not having a donor should not hold us back from transplanting. And I think that's something that happens in the United States. A lot of the patients never see us. A lot of the patients never get HLA typed. We never get a chance to do an unrelated donor search. We come in the picture too late. And by the time patients relapse, our outcomes deteriorate. We often don't have time to identify those donors. So I think it's important that patients get referred early. Another thing is that people think the patients are too old, but too old is a relative concept. Too old means over 50, and I found out that I'm over 50 now, and I don't think I'm too old yet. And this is again from Kurosawa. They looked at older patients, age 50 to 70, from 67 centers, and they looked, this is not randomized, this is looking at outcomes, this is who gets transplanted, who doesn't get transplanted, the various approaches, some with myeloablative, some with reduced intensity. Only a small percentage got transplanted, but again, the outcomes are quite superior for transplant. And if anything, the benefits of transplant may extend more to the older patients, because the older patients have often higher risk disease. Even if they have a remission, very few are cured. And age by itself is a very poor predictor of a transplant outcome. There's much more powerful predictors, no time to go into it, but they include performance status, they include comorbidities, they include more and more measurable factors such as CRP and ferritin. So I don't think people should be held back from transplant because they're over 50, far from it. The same here, this is an MD Anderson study, and Dr. Chamberlain is very aware of this, I think. They did a prospective study, again in patients over 50. Was it possible to transplant them in first remission? And how were their outcomes? And I'll come back to this study, but just here now showing you the outcomes, those over 50 that underwent the transplant, it was a minority again, but had clearly a far superior outcome than those that didn't get a transplant. So again, the AC220s, the FLT3 inhibitors, the novel agents are all fascinating, and we should not lose our enthusiasm about this, but we should also not lose our enthusiasm for these established treatments that have much improved and that are curing patients, and one should not go at the expense of the other. So I think a big problem is that our leukemia doctors, our friends and colleagues, just don't think about transplant. And they call us too late, and the patients don't get transplanted. And I want to go back to this MD Anderson study that I just showed you, where there were 259 patients over the age of 50. 99 achieved a CR. This showed us a bigger problem. Not everybody achieves a CR. 46% never got a transplant consult. That was probably the major reason not to get a transplant. There was never a transplanter involved. And what were the reasons that they didn't get transplant? Sometimes they were too ill, sometimes they refused, all legitimate reasons. But many of them, it was unclear. I think it was forgotten. It was in the big rush of things. You need to get patients through their induction chemotherapy. You worry about their fungal infection, and the HLA typing doesn't get done. Same in this Japanese study from Kurosawa, 2,029 patients. 953 never got their HLA typing checked. How can we ever get to a transplant if we don't even know their HLA typing? And these are not developing countries. These are two of the most advanced medical technology countries in the world. So there's a bit a disconnect there. Now, the relevant issue, I think, is the issue of chronic GVH. And I believe that's something where we as transplanters need to perhaps rethink what we are doing. We are a bit enamored with graft versus host disease and graft versus leukemia effects. It's fascinating. It's a biology that is very underlying much of what we do. And we tend to go back to these slides from 20 years ago that show that people who have graft versus host disease relapse much less than people who have no graft versus host disease, than people who have T-cell depletion. Keep in mind two things about these types of slides. One is this doesn't prove that the ones that had graft versus host disease lived longer. Sometimes they lived less long in individual cases because of the side effects of the mortality and morbidity of graft versus host disease. And second, a lot of the patients in these series had CML, and that's a disease that has disappeared. Data from Seattle kind of underpinned this. They showed, and I have trouble seeing my own slides here, but they showed that patients in reduced intensity conditioning, clinical extensive disease had much less relapse than than those that didn't have chronic GVH, and had, at least in the short run, because follow-up on these studies was rather short at the time this was published, at least in the short run, chronic graft versus host disease was associated with improved progression-free survival. I'll try to argue that this is no longer really true. I would say chronic graft versus host disease affects quality of life, may actually shorten life, and in AML does not affect the relapse rates. Again, it is not a trivial issue. If you look at this Markov decision analysis from the Japanese, depending on how much weight you assign to graft versus host disease, if you give somebody with graft versus host disease a quality of life of 60%, then transplant is favored in most situations. If their quality of life goes further down, the more it goes down, the more chemotherapy is favored. The less graft versus host disease, the more transplant is favored. So if we can do transplants without graft versus host disease and mitigate relapse still without graft versus host disease, we may get a lot more patients referred and a lot more patients come to us. Now, this is a study from Dan Weisdorf, presented at ASH, not published yet, but he was kind enough to give me the slides. And looking at, in this day and age, at myeloablative or reduced intensity conditioning, the effect of graft versus host disease on disease-free survival and overall survival. And as you see in this IBMTR International Transplant Registry analysis, having no graft versus host disease in 2011 is actually beneficial. It is better not to have graft versus host disease. It's not so good to have acute graft versus host disease. It's even worse to have chronic graft versus host disease, and it's even worse to have acute GVH and chronic GVH. So perhaps we should avoid this. Reduced intensity conditioning, the differences are less obvious, but there's definitely no advantage in survival of having chronic or acute graft versus host disease. At best, it is equal. For years, we have been doing CAMPATH, partial T-cell depletion. At some point, I compared this with MD Anderson, with Sergio's fludarabine melphalan, where only the unrelated donor transplant recipients received ATG. And what we found, comparing data from the University of Chicago and MD Anderson, only MDS and AML, is that survivals and progression-free survival were equivalent, graft versus host disease was acute, and chronic graft versus host disease was quite equivalent, was quite worse at MD Anderson. So point being, similar to what you heard this morning in the session on thymoglobulin, that partial T-cell depletion, be it with Campat, be it with one of the ATGs, may maintain remission rates while avoiding graft versus host disease. The last point is that to really notice the long-term impact of graft versus host disease, you need more than 2 years follow-up. This is what I think an important study, again from the IBMTR, looking at 2-year survivors after transplant. So these are patients that are cured after transplant, and comparing their long-term lifespan, life expectancy, with that of contemporaries. So US females, healthy US males. As you see, a transplant may be curative, but even if you're cured from a transplant, you unfortunately still end up dying. And you end up dying at a higher rate than the regular, we all end up dying, but you die before you should compared to your contemporaries. Half of this is late relapse. There are still people relapsing, and we all know that. But the other half is late complications. And there are late complications of many of transplant, and many of them, again, related to graft versus host disease. And in this series, if you look, subdivide the patients into those who do not have chronic graft versus host disease with those who have chronic graft versus host disease. The ones who do not have graft versus host disease, 92% of them are alive 10 years later, so 12 years after their transplants. The ones that have chronic graft versus host disease, only 73% are alive. So 25% of these people have passed away from a variety of complications. So I think we don't, and we are aware of that as clinicians, but we don't emphasize this enough in the literature as far as I'm concerned. There is long-term debilitating consequences related to bronchiolitis, related to ongoing infections. This is a study that you've already seen repeatedly, the Fresenius study, an unrelated transplant, where, again, similar to our Flumel-Campat data, unrelated transplant, Fresenius ATG results in similar survival, much better survival without graft versus host disease medications, and much less chronic graft versus host disease. So, in summary, allotransplant to me is superior treatment for young patients with intermediate risk disease, for older patients. It is at least equivalent for many others. Donor availability is no longer an issue, but the benefits of transplants are diminished considerably by the detrimental long-term effects of chronic graft versus host disease. The important thing, though, I think, is what are we arguing about? We are arguing, this is the Dutch study again, we are arguing transplant versus no transplant. We are arguing about 10% difference. The real difference that we need to make is in the many patients who still fail our treatment. So I actually think the future is in combining these types of treatment. Somebody was asking me yesterday, we need to design studies where we combine the novel agents with transplants, where we combine cellular therapies with transplants, and try to further improve our outcomes. Thank you.